السلام عليكم ورحمة الله وبركاته. Welcome to Start MRCOG with Hala. Today I will explain renal transplantation in pregnancy. My reference is two TOG articles, Solid Organ Transplantation in Pregnancy 2016, and the other one is Management of Women with Chronic Renal Disease in Pregnancy 2009, which include part about the renal transplantation. We will start by information gathering, usually by history, examination, and investigation. And the history here should be target history. Include talking about renal transplant history and our aim to assess the severity of the condition, including the etiology, the renal disease, because it could be genetic, could be diabetes, systemic lupus erythematosus. All of them can affect the outcome and of the effects of the disease on pregnancy and vice versa. And when renal transplantation was done, last visit to the specialist, last kidney function tests, and last blood pressure, if she had any other complications like infection, urinary tract infections, because outcome is affected by etiology, for example, diabetes, and because pregnancy is not advised in the 12 to 18 months after the renal transplant, and the TOG, they specified 1 year. Because outcome is affected by the basic kidney function test, routine in urine, and blood pressure, whether the patient is hypertensive on medication or no. In addition to other points which cover relevant general history, like in the medical condition, other medical conditions, if she's already on contraception, if she has any allergies, and her BMI, and if she has special habits like smoking, drugs, alcohol, and the level of support. Being with chronic medical condition, we have to assess her level of support and also add to this the psychological well-being and the coping with the condition. Examination, if you are in a structured discussion, you will tell that you need to know her blood pressure, check her blood pressure and her BMI if it was not given to you in the scenario. We divide the patient care into preconceptional, antenatal, intrapartum, and post-delivery. Our aim from the preconceptional care is to prepare the patient for the best outcome, prepare her health for the upcoming pregnancy. From strategies, they mentioned about the timing of the pregnancy in more details and arranged. So they mentioned that pregnancy is recommended after 12 to 18 months of the renal graft transplantation. There should be no rejection in the previous year of the graft, and graft function should be adequate and stable. Creatinine should be below 1 micromole per liter. No or minimal proteinuria, less than 500 milligram per 24 hours. The woman should be on maintenance immunosuppression and a stable dosage, for example, prednisolone 15 milligram per day, azathioprine 2 milligram per kg per day, cyclosporins 5 milligram per kg per day. There should be no acute infections because some infections can affect the baby, like cytomegalovirus. Any comorbid condition should be controlled, like hypertension, diabetes. Normal kidney ultrasound. We have to review the medications. So she should optimize the dose and the regimens of the immunosuppressive medication before embarking on the pregnancy, and then she should continue on the pre-pregnancy dosages. Of course, the calcium level is affected by the pregnancy, so blood level and dose adjustment and at least calcium level no less than monthly should be checked, because excretion increasing the pregnancy, higher dose is required. Folic acid and aspirin, folic acid 400 micrograms. Only we increase to 5 milligram if the patient is diabetic or obese. But in renal disease, 400 microgram is the recommended dose, like any other pregnancy. Aspirin 75 milligram from 12 weeks and no The patient should discontinue teratogenic medications like mycophenolate mofetil or MMF because it increases malformations in the baby and lead to first trimester pregnancy loss. Some malformation like external ear and other facial malformations such as cleft palate and lip. And we have also biologics like rituximab, sirolimus and everolimus, and all not recommended during the pregnancy, but they mention that if the benefit outweigh the risk, it could be used with some precautions, like to stop them around 32 weeks, and the baby should avoid the live attenuated vaccines until the blood of the baby is free from the medication. Statins should be stopped before the conception. It is a very essential part in maternal medicine module to explain to the patient the implications or the effects of the condition on her pregnancy and vice versa. And here I will explain the effects of the condition on the pregnancy itself. They present in both TOG articles a set of effects. There's more details in TOG 2009, including that 95% of gestations end successfully, so we can reassure the patient. The incidence of miscarriage and congenital anomalies is similar to the general population, despite in strategies they mention different figures, but we need to follow the TOG. And the ectopic pregnancy rate is higher, and this is related to adhesions from previous surgery and peritoneal dialysis. Hypertension usually precedes the pregnancy or predate the pregnancy in about 70% of the kidney transplant recipient, and in 2016 they mentioned more than 50%, so nearly the same. Superimposed preeclampsia and urinary tract infection occur in up to 40% of these women. Acute bacterial pyelonephritis is common. Higher risk of gestational diabetes, particularly pregnancy diabetogenic, and the medications she receives also diabetogenic. That's why gestational diabetes is a risk. Increased risk of preterm delivery, whether spontaneous or iatrogenic due to complications. Having a premature rupture of the membranes, fetal growth restriction is very high as 60%. Opportunistic infections are common in immunosuppressed. And these infections can affect the baby, like cytomegalovirus, toxoplasma, herpes. So now these are the implications of the condition on the pregnancy. Coming to the effect of the pregnancy on the graft. In 2009, they mentioned that effect on the chronic rejection is not known, but acute graft rejection they specified. In 2016, they mentioned 10 to 15% incidence of graft rejection in the first year, and usually happen in women under the age of 45. During pregnancy, all depend upon how she started her pregnancy. So if she had, at the start of the pregnancy, stable graft function 1 year after transplantation, so the risk depends upon presence of hypertension and proteinuria. And if we suspected graft rejection, we have to arrange for kidney biopsy, and there could be some risk of bleeding if we did the kidney biopsy during the pregnancy. And if it happened during the pregnancy, it's usually treated by corticosteroids and optimization of the tacrolimus and cyclosporins, and some biological agents could be given. Now, we will discuss the antenatal management of renal transplant recipient. Usually, we start by the multidisciplinary team and enumerate them, including the obstetrician, the consultant, and local transplant team, midwifery support. We have to start usually by the organ. So here we have the kidney, which will be a major concern for the patient. So we have to evaluate baseline kidney function. We have set of kidney function tests: urea, electrolytes, creatinine, estimated glomerular filtration rate and protein creatinine ratio, 24-hour protein in the urine, midstream urine. So this kidney function test should be done like a baseline and should be repeated. And there is a suggestion it should be repeated at least every month, together with the calcineurin, including tacrolimus and cyclosporin level. So this is the organ. Coming to the obstetric complications, mainly in renal patient, we have to remember vena thromboembolism, and we have to assess all risk factors for VT in this patient. And one of the factors, indication for low molecular weight heparin, is having protein creatinine ratio more than 300 milligram per millimole, or albumin creatinine ratio is greater than 180 milligram per millimole. We will take it trimester wise. So at the end of the first trimester, of course, in the first trimester, folic acid 400 milligram. And when we come to 12 weeks, we have to do the routine dating scan. During the time, usually we arrange for the aneuploid screening, combined test. But here it could be somewhat not reliable, because excretion of beta HCG, one of the hormones which is assessed during the combined test, could be baby may have fetal growth restriction. That's why we will arrange for monitoring of the baby growth at 26 to 28 and then 32 to 34 weeks according to TOG article. Please, if you are in structured discussion, usually mention your reference, because usually they put in the mark that you have to use the available evidence. Then gestational diabetes. Usually we do 24 to 28. I mentioned that the calcineurin inhibitors, steroids, can affect the blood glucose level. Oral glucose tolerance test could be used. In case where there is strong suspicion, blood sugar monitoring should be arranged. Risk of anemia is in kidney patient because of erythropoietin hormone is affected. So we will monitor by full blood count, and then if the patient needs, she will receive iron, but sometimes it is not effective, so she will need erythropoietin. But sometimes also it could be contraindicated, like in presence of hypertension, and in this situation, this patient rarely need to receive blood transfusion. And plan for the mode of the delivery should be discussed with the woman together with the consultant and MDT, including the renal transplant team, around 30 to 34. And this early timing for discussion about the plan, because this patient may go into early delivery, preterm delivery, so she will have her plan ready, and also versus vaginal delivery, which is renal transplant is not contraindication for having vaginal delivery. Blood pressure and preeclampsia is a must to be discussed in any renal patient. We have to follow the blood pressure through the pregnancy. If hypertension develops, we have to treat by alpha-methyl-dopa, labetalol, nifedipine, all are safe during the pregnancy, and we have to maintain the blood pressure below 140/90 mm mercury. We have to be vigilant about preeclamptic toxemia by measurement of the blood pressure and protein every visit, and starting aspirin from low-dose aspirin 75 from 12 weeks. And if the patient develop preeclampsia, they mentioned that magnesium sulfate is safe, loading dose is the same, but maintenance should be halved. And in addition to the other monitoring of the patient, when we give the magnesium sulfate, including respiratory reflex and so on, should be applied. Coming to the intrapartum management, regarding the timing, in TOG 2009, they specified between 34 to 40 weeks we need to deliver the patient. Our aim is to go into spontaneous delivery. The aim is vaginal delivery, cesarean section for obstetric indications, and monitoring of the mother, monitoring of the baby by continuous CTG, monitoring fluid balance. No contraindication to induction of labor using prostaglandins, oxytocin, all are safe. It should be at hospital under consultant. The same multidisciplinary team, including renal transplant, should be included. Risk of renal transplant injury during cesarean section 1 to 2%. This is important figure. And skin incision First, we have to localize the graft by ultrasound scan in order to reduce the risk of renal injury. And we need to start by midline incision. Experienced staff should do the surgery because of adhesions and the presence of the kidney. Midline incision and uterine incision will be like usual, transverse lower segment incision during cesarean section. The woman needs a steroid dose of steroids. If she was in prednisolone, more than 7.5 milligram. Some medications are contraindicated like ergometrin. Misoprostol, carboprost is not contraindicated. Coming to postpartum management of renal transplant recipient. Coming to postpartum management. Before discharge from hospital, blood pressure should be stable, lower than 140/90 mm mercury. And given follow-up appointment, including joint clinic with the renal transplant team. She should be on safe and effective contraceptive method. And the breastfeeding medication should be adjusted according to the situation of the breastfeeding. If the patient was indicated to take ACE inhibitors, the recommended one to prescribe enalapril, which has safety data in breastfeeding. While she's in immunosuppressive medications, it is controversial during the breastfeeding. But they mentioned that this contraindication is not absolute, and new evidence is emerging regarding low level of drug excretion into the breast milk. For example, according to 2009, they mentioned neonatal problems like thymic atrophy, transient leukopenia, thrombocytopenia, and adrenocortical insufficiency could happen to the baby.